Welcome everyone. In this video we shall be talking about rheumatoid arthritis and discuss most of the important questions related to it. So moving on to the first question. A patient with long-standing rheumatoid arthritis presents with the following deformity as shown in the image below. What is the underlying anatomical defect causing this specific presentation? So in this image we can very well appreciate that there is PIP flexion. There is PIP flexion deformity. And in the DIP we can very well appreciate the extension. There is extension in the DIP. Okay. Now something important that we need to remember, that in rheumatoid arthritis a DIP joint is spared. DIP joint is spared. As a result, this DIP extension is not due to joint involvement. Because it is always spared. Okay. If our DIP joint is involved, then we can actually rule out rheumatoid arthritis. Okay. So this is actually due to tendon involvement. What happens and this specific deformity is known as Bottonier's deformity. Okay. So this Bottonier's deformity is actually due to rupture of the central slip of extensor digitorum tendon. What happens? This extensor digitorum tendon has actually two parts, right? It has two parts. It has a central slip, and it has two lateral slips. Okay. This central slip is actually for PIP extension and these two lateral slips are for DIP extension. Okay. So when this central slip is ruptured, in rheumatoid arthritis, your PIP extension would be absent. Right? But the flexors are acting normally. That's why you would get a PIP flexion deformity. Okay. And these lateral slips are actually intact. And that's why we get this DIP extension. Okay. So that's why we get this Botonier deformity. If we look into the other options, rupture of the volar plate would actually cause hyperextension. Hyperextension of the PIP joint. Okay. Whereas contracture of the intrinsic muscles would lead to intrinsic cross deformity. It is also seen in rheumatoid arthritis. Over here we get MCP flexion. Deformity. Okay. And tenosynovitis of the flexor digitorum superficialis. Over here, your PIP flexion would become difficult. Okay, because the flexor digitorum superficialis tendon is involved. Okay. So again, this won't be a answer because we are getting a flexion deformity. How come flexion deformity be there if the flexor tendons are involved? Okay. So our answer over here would be option D, rupture of the extensor digitorum tendon. Moving on to the next question. Which of the following radiological findings is considered the earliest specific sign for rheumatoid arthritis on plain X-ray of the hand? So remember it as a fact that it is juxta-articular or peri-articular osteopenia. Okay. What happens in rheumatoid arthritis? In rheumatoid arthritis we have synovitis. Synovitis is inflammation of the synovium. Now this inflammation results in increased blood flow to the joints, and this inflammatory hyperemia actually causes increased osteoclastic activity in the joints, and this osteoclastic activity results in periarticular or juxta-articular osteopenia. Okay. If we look into the other options, the subchondral cysts are actually seen in osteoarthritis. Penicillin cup deformity is quite characteristic of psoriatic arthritis. Whereas symmetrical joint space narrowing can be seen in RA, but remember it is a late feature in RA. The earliest feature is juxta-articular or periarticular osteopenia. Okay. Moving on to the next question. Now, a 50-year-old male with rheumatoid arthritis for 15 years presents with splenomegaly and persistent neutrophil count of just 800 per millimeter cube. What is the most likely diagnosis? Excuse me. Now remember that whenever we get a triad of rheumatoid arthritis plus splenomegaly plus neutropenia, right? Without doubt, our answer would be Feltis syndrome. This triad of rheumatoid arthritis, splenomegaly, neutropenia is nothing but a Feltis syndrome. Why does it occur? It is actually an immune mediated destruction of neutrophils. immune mediated destruction of the neutrophils, and is associated with extra-articular RA. Of course, it is a hematological feature. It should be associated with extra-articular RA. So then this persistent low neutrophil count increases the risk of infection and even sepsis. Okay. If we talk about the other options, right, amyloidosis occurs in chronic inflammation. Yes, in rheumatoid arthritis we can get amyloidosis, but amyloidosis in rheumatoid arthritis would cause renal involvement, mostly in the form of nephrotic syndrome. Kaplan syndrome is nothing but rheumatoid arthritis plus pneumoconiosis. Okay. And Still's disease is actually associated with juvenile rheumatoid arthritis. It's associated with the juvenile variety, right? And over here the age of the patient is 50, so it cannot be Still's disease. Still's disease is also associated with fever, with lymphadenopathy, and a salmon rash. Okay, in a juvenile RA patient. Okay, so our answer over here would be Felty syndrome. Moving on to the next question. Now, in 2010, in the 2010 ACR or EULAR classification criteria for rheumatoid arthritis, a patient must score at least how many points to be classified as definite RA, right? Again, we have talked about the ACR criteria in Sjogren syndrome in our video on Sjogren. This time we shall be talking about this ACR criteria for rheumatoid arthritis. ACR criteria in RA. We have 4 broad categories, of which the first one is joint involvement. Under joint involvement, first is if there is one large joint involvement, we give a score of 0. If there are 2 to 10 large joint involvement, we give a score of 1. Then we have 1 to 3 small joint involvement, with or without large joint, we give a score of 2. Then we have 4 to 10 small joints, with or without large joints, right? Again a score of 3. And if more than 10 joints are involved, of which at least one small joint is involved, then we give a score of 5. Okay, this is about the joint component. After joint component, we have the serology component. Under serology, we have 3 things. If both rheumatoid factor and anti-CCP are absent, we give a score of 0. Of course, both of them are absent, 0. If low positivity is found in either RF or anti-CCP, we give a score of 2. And if it is high positive, any one of them, if it is high positive, then we give a score of 3. Okay. Then the third component is acute phase reactants. Okay. If we get normal ESR, or CRP, we score of 0. And if it is elevated ESR or CRP, we give a score of 1. And the final criteria is duration. If it is for less than 6 weeks, we give a score of 0. And if it is for more than 6 weeks, more than equal to 6 weeks, we give a score of 1. So total it can be 1, 3 and 5. At most it can be 10. And when do we call it definite RA? When it passes 6 points. Okay, remember it. When it passes 6 points, we call it definite RA. So this ACR criteria is quite important. We need to remember this. Okay. Moving on to the next question. Now, a patient with RA develops the following deformity as shown in the image. What is the defining radiological feature in this severe variant of the disease? What is this deformity? This deformity is known as the opera glass deformity, also known as arthritis mutilans. It is also known as telescoping fingers, right? We can very well appreciate these things, right? That the finger, the joints, the bones have telescoped into one another. Now, what is the radiological feature? What happens over here? Normally, our phalanges are something like this. So, with massive osteolysis in rheumatoid arthritis, what happens is that they get eroded towards the ends and they enter into one another. They enter into one another. Something like this happens. And that's why the fingers get pushed into itself, right? That's why we are getting this arthritis mutilans or telescoping of the fingers, right? Even in radiology, in the radiographic finding, we would get the same thing. We would get extensive resorption of the bones leading to telescoping of the fingers. Okay. Moving on to the next question. Now, a 60-year-old male with long-standing RA presents with pleuritic chest pain. Thoracocentesis reveals a straw-colored fluid. Which biochemical characteristic of this fluid is most diagnostic of rheumatoid pleurisy? Remember, if we talk about pleural effusion in rheumatoid arthritis, it happens, we all know that pleural effusion in rheumatoid arthritis is an inflammatory condition, So if we talk about the characteristic, it would be exudative. Okay. Now this inflammation means there is increased inflammatory infiltrate, increased neutrophil infiltration, which would result in utilization of glucose, So we would get decreased glucose, and not only decreased glucose, it would also be associated with a lower pH less than 7.2 and increase in LDH, of course, because of the cell destruction over there. Besides that, this inflammatory condition is due to the in rheumatoid arthritis. The inflammation is actually set via these immune complexes, These immune complexes, I'm extremely sorry for the background noise, right? These immune complexes results in complement activation. Okay. And due to this complement activation, there would be decreased complement proteins, specifically C3 and C4. And of course, we would get increased rheumatoid factors. So these are the characteristic findings that we are going to get in a pleural fluid. So low LDH levels, no. High glucose levels, no. Low glucose levels and low complement levels, this should be our answer. And predominance of eosinophils is seen in hypersensitivity reactions, right? Rheumatoid arthritis does not result in hypersensitivity reaction. Okay. So answer should be option C. Okay. Moving on to the next question. Now, a patient with rheumatoid arthritis is undergoing cervical spine X-ray before an elective surgery. What is the maximum normal limit for atlantodental interval in an adult to rule out significant atlantoaxial subluxation? And remember that in a patient with rheumatoid arthritis, there is an increased risk of atlantoaxial subluxation, right? And it actually precipitates during intubation, right? During surgery, right? So what do? We measure this ADI, right? Atlantodental interval. What is this? It is actually the distance. Between 2 points. It is actually the distance between the posterior surface of the anterior arch of C1 vertebra, and the anterior surface of the odontoid process of C2. This is our ADI. Okay. Now, what is the interpretation? Remember three things about ADI. ADI more than 3 in adults, and ADI more than 3 centimeters. 3 millimeters. 3 millimeters and 5 millimeters in children. It is more than 3 millimeters in adults and more than 3 millimeters in children. This is suggestive of instability. It is suggestive of instability. There would be increased risk of subluxation during intubation. Okay. And if the ADI is more than equal to 10 millimeters, it is suggestive of increased risk of cord compression. Okay. So over here, they asked us about significant atlantoaxial subluxation in an adult. So our answer over here would be 3 millimeters. These three values are important. 3 millimeters in adult, 5 millimeters in children, 10 millimeters would result in increased risk of cord compression. Okay. Sorry for the cut. Moving on to the next question. Which of the following ocular complications are associated with rheumatoid arthritis? Episcleritis. Yes, episcleritis is rather the most common ocular complication that is associated with rheumatoid arthritis. Scleromalacia perforans, yes, it is the most severe manifestation. What happens? This is actually due to recurrent scleritis, right, which results in granulomatous inflammation. And there is an increased risk of perforation. In such a patient. Okay. Keratoconjunctivitis sicca, yes, we have read that keratoconjunctivitis sicca is actually a manifestation of Sjogren's syndrome. So this keratoconjunctivitis sicca is actually associated with secondary Sjogren's syndrome, the ones that are associated with rheumatoid arthritis. We have actually read in our video on Sjogren's syndrome that the most common association of Sjogren's syndrome, secondary Sjogren's syndrome is rheumatoid arthritis. Okay. And peripheral ulcerative keratitis, yes, this is also seen. This is actually immune mediated. This is actually immune mediated corneal ulcer. Immune mediated corneal ulcer. So technically our answer would be all of them. Option D. Remember that the ocular complications that are not associated with RA, number one is uveitis. Number two is retinal vasculitis. Okay. These are the two manifestations that we won't get. Okay. Moving on to the next question. Regarding the cardiovascular risk in rheumatoid arthritis, which statement is most accurate according to the EULAR recommendations? Remember that in rheumatoid arthritis we all know that rheumatoid arthritis is an inflammatory condition. Okay. So there is an increased risk of cardiovascular disease in rheumatoid arthritis. Okay. This is the baseline thing that we know. Now let's have a look into the options. Rheumatoid arthritis patients have the same cardiovascular risk as general population. That's a false statement. There is an increased risk. Okay. Standard cardiovascular risk scores should be multiplied by 1.5 for RA patients. Yes, this is the true statement. Yes, this 1.5 is actually the correction factor, because we all know that there is an increased risk of cardiovascular diseases, right? Rheumatoid arthritis increases the severity of cardiovascular diseases. That's why we need a correction factor. If the normal cardiovascular risk scores are something, we would just multiply it by 1.5 to show that rheumatoid arthritis increases the severity, right? Does have some role in increasing the severity. Okay. TNF inhibitors significantly increase the risk of myocardial infarction. That's a false statement. Why? Because this TNF inhibitors actually decreases inflammation. They also improve endothelial. They also improve the endothelial function, right? Increasing endothelial function and decreasing inflammation, they would rather decrease the risk of cardiovascular disease. And cardiovascular deaths is rare in RA. That's a false statement. Rather, cardiovascular deaths are the most common cause. Of deaths in RA. Okay. So the answer over here should be option B. Okay. Moving on to the next question. Now, 52-year-old male with RA and high titers of RF, presents with dry cough and exertional dyspnea. His HRCT is shown in the image below. What is the ILD pattern most likely? Okay. Rheumatoid arthritis, and we got ILD, and in ILD we can very well appreciate this honeycombing. Right, and we all know that honeycombing in an ILD is very much characteristic of UIP, or usual interstitial pneumonia. Remember it as a fact that for most of the rheumatological disease, if we have an associated ILD, that is going to be NSIP. Right, mostly it is an NSIP, but in rheumatoid arthritis, this is a very big exception for rheumatological diseases, right? We get UIP as the ILD pattern. Okay. So this honeycombing also suggests us of UIP, and rheumatoid arthritis where we do get UIP only. So our answer would be answer A, usual interstitial pneumonia. Okay. Remember it as a fact that it is UIP for rheumatoid arthritis and NSIP for most of the other rheumatological diseases. Okay. Moving on to the next question. A patient with rheumatoid arthritis presents with severe pain in the left cuff and swelling, mimicking deep vein thrombosis. Ultrasound reveals a collection of the fluid in the cuff muscles originating from the popliteal space. What is this condition? Now, this is a very characteristic description. Remember that in a rheumatoid arthritis, if there is pain in the cuff muscles, plus fluid accumulation in the popliteal space, right, it is without doubt is ruptured Becker cyst or ruptured popliteal cyst, right? This is actually located between the semimembranosus muscle and the medial head of gastrocnemius. Between this we have this popliteal cyst, and it ruptures due to actually synovial fluid distension. It ruptures and there is spillage of the synovial fluid into the cuff muscles. In a rheumatoid arthritis patient, whenever we get this, that is ruptured Becker cyst. A very classical presentation. If we talk about the other options, rheumatoid lymphedema may we would get chronic swelling and not an acute swelling like this. And saphenous vein thrombophlebitis and gastrocnemius tear, in these two things, this fluid accumulation would be absent. And remember, this condition actually mimics DVT, right? This has also been mentioned in the question. Right? These are characteristic presentations. Okay. So our answer would be option D, ruptured Becker cyst. ठीक है. Moving on to the next question. Match the following biological DMARDs with their specific molecular targets. Now this is quite factual. Remember that abatacept actually acts on this, yes, CD8086, the co-stimulatory molecular T cells, and they prevent T cell activity, Tocilizumab is actually a monoclonal antibody that acts against interleukin 6 receptors. Anakinra is interleukin 1 receptor antagonist, and etanercept is actually a decoy receptor. For this TNF alpha receptor fusion protein. ठीक है. So our answer should be A3, B4, C1, D2. C1, D2. Option A should be our answer. ठीक है. Remember the targets, right? Remember the targets. These are quite important, these DMARDs. ठीक है. Moving on to the next question. Now, a 28-year-old pregnant woman with RA requires treatment for a flare. Which of the following DMARDs is considered safest to continue during pregnancy? Now, before we talk about pregnancy, let's have a look into this management. Let's have a look into management of rheumatoid arthritis in general. Now, if we get a flare, then the only thing that we can do is use steroids. Use steroids. But remember that if only 1 to 2 joints are involved, then we can go for intra-articular triamcinolone. ठीक है. But if we get more than 2 joints, right, then we need to use oral prednisolone. ठीक है. Oral prednisolone. ठीक है. But for maintenance, we would use the DMARDs. The drug of choice is methotrexate. ठीक है. With methotrexate, if the drug of choice is methotrexate, if there is no response in 3 to 6 months, with methotrexate, then we would actually add the drugs. Then we would actually add the other DMARDs. Number 1, what are the options? We have sulfasalazine, right? Then we have hydroxychloroquine. Then we have other biologicals. Okay, like anti-TNF alpha, interleukin 6 inhibitors, like all the drugs that we have read in the previous table, right? All those things we can add. Okay, so the drug of choice is methotrexate, but this methotrexate cannot be used in pregnancy, right? Now, if we talk about their use in pregnancy, methotrexate is a dihydrofolate reductase inhibitor. It decreases folate, so it will cause NTDs, neural tube defects. So this is absolutely contraindicated. If we talk about tofacitinib, it is an extremely question mark thing, right? Not much data is present. That's why it is better to avoid it. Avoid tofacitinib. And leflunomide is also highly teratogenic. Okay. So our only option that is left with us is sulfasalazine. Yes, sulfasalazine can be used even in pregnancy, right? Something important that I wish to tell you over here is leflunomide, right? Leflunomide is very teratogenic. If someone is planning for, a lady who is suffering from rheumatoid arthritis is planning for pregnancy, then she should stop the drug, and not only stop the drug, there is something called cholestyramine washout. Cholestyramine washout has to be performed before conception. Okay, if she was using leflunomide. Okay, so the answer over here should be sulfasalazine. This can be used safely in pregnancy. Okay, moving on to the next question. The drug sarilumab is an FDA approved biological for RA. How does its mechanism of action differ from tocilizumab? Remember that both sarilumab and tocilizumab are monoclonal antibodies that acts against interleukin 6 receptor. So what is the basic difference? This tocilizumab is a humanized monoclonal antibody, whereas sarilumab is a fully human monoclonal antibody. This is the difference. If you look into the options, it binds directly to interleukin 6 cytokine rather than the receptor. No, the drug that does so is known as siltuximab. Okay. This is the one that directly binds to the cytokine. Okay. It is a fully human monoclonal antibody. Yes, this should be our correct answer. It is a TNF alpha inhibitor, whereas tocilizumab targets interleukin 6. No, it is TNF alpha inhibitors. We have infliximab. We have infliximab. We have etanercept. We have certolizumab. we got we have golimumab, we have golimumab, we got adalimumab. These are the things which are TNF alpha inhibitors. Okay. And small molecule inhibitors of interleukin 6 signaling cascade, no, this is for the JAK inhibitors, tofacitinib. Okay. So the answer over here would be option B. Moving on to the next question. A patient on methotrexate for rheumatoid arthritis develops progressive fatigue. And the peripheral smear of the patient is shown in the image below. The peripheral smear is shown in the image below. What is the most likely underlying mechanism of the condition? Most likely underlying mechanism of this condition. In this image, we can very well appreciate over here a hypersegmented neutrophil. We get a hypersegmented neutrophil, and we can also appreciate the ovalocytes or the macrocytes macrocytes plus hypersegmented neutrophils. The condition is nothing but our megaloblastic anemia. So in methotrexate, you are getting megaloblastic anemia. What happens actually? Methotrexate inhibits dihydrofolate dihydrofolate reductase, right? As a result, our tetrahydrofolate reduces. This reduction in tetrahydrofolate results in decreased purine synthesis, and decreased purine synthesis results in decreased number of lymphocytes, and decreased lymphocytes would actually decrease the inflammation that is present in our rheumatoid arthritis. Besides this decrease in purine, there is also actually accumulation of adenosine, and this adenosine also has anti-inflammatory action. It also decreases inflammation. So these two mechanisms actually help in rheumatoid arthritis. So something more that happens with decreased tetrahydrofolate is that we get a side effect. in the form of megaloblastic anemia, right? Because they are not maturing properly, right? Because the bone marrow cells are not maturing properly. So our answer over here would be functional folate deficiency. Okay. In iron deficiency anemia due to chronic NSAIDs, we would get microcytes. Direct bone marrow toxicity due to methotrexate. Yes, remember that one important thing, that we can get bone marrow toxicity in methotrexate, but that would cause suppression. That would cause complete suppression. So that's why over here option D is a better choice than option B. And autoimmune hemolytic anemia is out of the picture. Functional folate deficiency is a better choice than direct bone marrow toxicity of methotrexate. Okay. Moving on to the next question. Now a patient with RA was prescribed a drug which blocks lymphocyte proliferation and stabilizes lysosomes. After using the drug for a long time, he developed distorted vision. Ophthalmoscopic examination of the patient is shown in the image below. Which of the following drugs is being prescribed to the patient? Now over here we can very well appreciate this is nothing but a bullseye maculopathy. What is bullseye maculopathy? What happens in bullseye maculopathy? Right, the central fovea is actually spared, and the peripheral and the surrounding retinal pigment epithelium gets damaged or gets involved. Okay. Now this specific side effect of bullseye maculopathy, along with the mechanism that has been given, stabilization of the lysosomes, both of them point towards only one drug, that is hydroxychloroquine. Hydroxychloroquine is very strongly associated with bullseye maculopathy, but that has to be used for a very long time, right? 15-20 years, right? Okay. And the specific mechanism of action where it stabilizes lysosomes, right? Stabilization of the lysosomes is also seen in hydroxychloroquine. Okay. Sulfasalazine would cause GI upset, and hemolysis in G6PD deficient individuals. Infliximab would increase the risk of infection, even progressing to sepsis. Tofacitinib is associated with dyslipidemia and increased risk of infection. Okay. So the answer over here would be hydroxychloroquine. Okay. Moving on to the next question. Now the drug upadacitinib is a newer agent in rheumatoid arthritis management. What is the specific mechanism of action? Remember, it has a fact that it is a selective JAK1 inhibitor. If we talk about the JAK inhibitors, that are used in rheumatoid arthritis, remember only 3 drugs. Number 1 is tofacitinib. Right, tofacitinib is actually the most common JAK inhibitor to be used, and it is not selective. It inhibits both JAK1 and 3. Then comes baricitinib. Baricitinib inhibits JAK1 and 2. Baricitinib inhibits JAK1 and 2. Whereas finally we have this upadacitinib. This is a selective JAK1 inhibitor. Okay, these are the only 3 JAK inhibitors that we need to know over here. Okay, and tofacitinib is the most common one, and selective JAK1 is upadacitinib. Okay, moving on to the next question. Match the following deformities seen in RA correctly. So over here in this thumb we can very well appreciate this is the Z deformity. This is the Z deformity. In the leg we can very well appreciate this is the hallux. This is the hallux valgus. And over here we can very well appreciate that there is DIP flexion. There is DIP flexion and PIP extension. Just the reverse of Bottonia deformity. This deformity is actually known as the swan neck deformity. And over here we can very well appreciate this is the piano key deformity. This piano key deformity is actually due to rupture of the ulnar collateral ligament. Is due to rupture of ulnar collateral ligament. Okay. Now we need to match them, right? Number 1 was Z deformity. A has to be 3, A3, B2, C1, D4. A3, B2, C1, D4. Option C should be an answer. These images are quite important. That's why I've included in the form of a match the following question. And I think with this we discussed most of the things regarding rheumatoid arthritis. If you like this video, consider subscribing to my channel, and thank you for watching.